Hi, this is Dr. McGinley providing another lecture to you. This lecture addresses gestational diabetes, known as GDM. Make sure you have viewed and listened to the Khan Academy video on diabetes and pregnancy prior to listening to this lecture. We will begin with a review of what constitutes gestational diabetes. GDM is diabetes that is diagnosed during a pregnancy and typically develops in the late second trimester. Therefore, the risks of fetal anomalies associated with poorly controlled type 1 and type 2 diabetes are not present. However, there are times that a woman presents to the office pregnant, has risk factors for diabetes, is screened, and the results are positive. This patient's fetus will have an increased risk of anomalies to the heart, spinal column, and gut, similar to poorly controlled type 1 and type 2 diabetic mothers. GDM differs from diabetes type 1 and 2 because it was not present, at least that we are aware of, when the woman is not pregnant. It is similar to diabetes type 2 in that there is a degree of insulin resistance that occurs. So question: if a woman has diabetes type 2 and becomes pregnant, does she convert to a GDM? The answer is no. She continues to be classified as a type 2 diabetic who is now pregnant. Gestational diabetes is further classified as type A1 or A2. An A1 GDM pregnancy is controlled by diet alone, while A2 GDM typically has abnormal blood glucose levels in the fasting and postprandial state. An A2 GDM patient is managed with diet as well as oral medications such as metformin and/or subcutaneous insulin. There are numerous risk factors for developing GDM, as you can see on this slide. Therefore, it is important to obtain a thorough history at the first prenatal visit. The ethnic groups with the highest risk for GDM are Hispanics, Native Americans, South or East Asians, Africans, and Pacific Islanders. When you look at all of these risk factors, if a woman has numerous of them present at the first prenatal visit, most likely she will be tested earlier than women without the risk factors. Gestational diabetes is a concern because it causes complications during a pregnancy, including fetal macrosomia, which in turn can cause trauma during delivery. This trauma can be to the baby, as in clavicular fractures, fetal intolerance of labor, failure to descend into the pelvis, or becoming stuck in the pelvis. There can also be trauma to the mother as well. Macrosomia, which is a fetal weight over 4,000 grams, so that would be 9+ pounds, increases the chances of a surgical birth due to cephalopelvic disproportion. It is abbreviated CPD in a chart. The baby is simply too large to fit through the mother's pelvis. GDM increases the risk of developing preeclampsia as well as gestational hypertension. We screen women for GDM between 24 and 28 weeks gestation, wherever the next scheduled visit falls within this time frame. The patient is given a 50-gram carbohydrate load. This comes as a prepackaged liquid of 50 grams of sugar in a 150 50 ml solution. The nurse needs to instruct the patient about the test. Why is it done? How is it done? And when does she need to drink the glucola? Her blood is drawn 1 hour after she drinks the liquid. It is important that she not have a heavily carbohydrate-laden meal prior to drinking the glucola, as this may contribute to a false positive screening test. If the patient's 1 hour blood glucose is greater or equal to 140, and note, some advocate a value of greater or equal to 130, the test is positive, and the patient needs to have a 3-hour GTT done as soon as possible. This GTT is no different than a GTT done in the non-pregnant state. Now, pause the lecture and open your textbook to see the current abnormal values that are indicative of GDM. Then return to the remainder of the lecture. The therapeutic management of GDM is aimed at maintaining normal blood sugar levels through the remainder of the pregnancy to promote good outcomes for the mother and baby. Pause the lecture again and review the recommendations for diet, exercise, and glucose monitoring discussed in your textbook. You will find the information in Chapter 26. Then return to the lecture. The nurse must assess a patient's knowledge about medications that are prescribed to maintain optimal blood glucose levels, primarily metformin and insulin. Recall and review from Nursing 172 the patient education that is needed in regards to these two medications. The patient needs to be taught how to administer insulin, how and when to perform home glucose monitoring, as well as what she should do with the results. In addition, this patient needs to be scheduled for twice-weekly biophysical profiles to monitor the fetus. In some offices, it is done in the OB/GYN office, while others have to be referred to a fetal diagnostic center. Review your preclinical write-up in regards to fetal diagnostic testing. When the patient presents in labor, the nurse needs to assess the patient's blood sugar. Depending on the results, further blood glucose assessment and/or administration of insulin may be indicated. Once the baby is delivered, the nurse must monitor the baby for hypoglycemia. This will be discussed further in the lecture about newborn care. This lecture, as well as the Khan Academy presentation, addressed a common complication of pregnancy, gestational diabetes, which occurs in about 10% of pregnant women. Uncontrolled GDM is associated with poor maternal and fetal outcomes, so it is imperative that the physician and nurse work together to screen, treat, and monitor a pregnant woman diagnosed with this condition. Recall from the Khan Academy video, a patient with GDM has a high risk for developing diabetes type 2 in the future. Therefore, she needs to be screened with either a fasting blood sugar or a 3-hour GTT at the postpartum visit to be assured that she actually had only GDM, not type 2 DM, that happened to be found during a pregnancy. The patient needs to be screened periodically thereafter by her primary care provider. Thank you for listening to the lecture about gestational diabetes and pregnancy.